Hello students, I am Dr. Prakash, Assistant Professor, Department of Pathology, Aditya Jyogi Institute of Medical Sciences. Last class, I talked about nephritic syndrome. Hope you've all seen that video. This is a continuation of that video, and in this, we'll discuss about the causes of nephritic syndrome. First, we'll start with anti-GBM disease, and then we'll talk about anti-neutrophil cytoplasmic antibody associated glomerulonephritis, immune complex mediated glomerulonephritis. This will be studied in three headings. First, we'll talk about IgA nephropathy, then post-streptococcal glomerulonephritis, and then lupus nephritis. And then there is membranoproliferative glomerulonephritis. In this, again, there are two types, type 1 and type 2. And lastly, we'll talk about rapidly progressive glomerulonephritis. See, this is not a disease in itself, but all this anti-GBM, ANCA associated, immune and membranoproliferative, all this will end up in this entity called rapidly progressive glomerulonephritis. So we'll start with anti-GBM. This is an autoimmune disorder. Okay, this anti-GBM is an autoimmune disorder in which there are circulating autoantibodies against the proteins or the antigens in the glomerular basement membrane. So as the name itself suggests, anti-GBM. So there are autoantibodies against the antigens in the glomerular basement membrane. So when this autoantibody binds to the specific antigen in the glomerular basement membrane, to be specific, this autoantibody binds to the NC1 domain of the alpha chain of type 4 collagen in the glomerular basement membrane. So NC1 domain of the alpha chain of type 4 collagen present in the glomerular basement membrane. So once this autoantibody binds to this antigen in the glomerular basement membrane, there is complement activation. As a result, there will be pro-inflammatory recruitment of pro-inflammatory cells, and CD4 and CD8 lymphocytes also will be recruited, and then there will be release of pro-inflammatory cytokines, chemokines and proteolytic enzymes. As a result, there will be endothelial cell detachment, and beneath this endothelial cell detached area there will be fibrin deposition, and finally there will be a break in the glomerular basement membrane leading to leakage of plasma proteins and cells into the Bowman space, and further there will be formation of crescents. See, the crescent formation is a classic feature of rapidly progressive glomerulonephritis, and the literal meaning of the word crescent is to increase or to grow. Okay, so what happens in crescent formation is, in the Bowman space there will be increase in the cellularity because of this damage to the capillary wall. So this is called as crescent formation, and this is a classic feature of rapidly progressive glomerulonephritis, and 90% of the cases of anti-GBM or Gould-Pasteur syndrome will end up in rapidly progressive glomerulonephritis. That is, formation of crescents will be seen in this 90% of cases. So we'll see some pictures. So this see, I told you that 90% of the cases of anti-GBM or Gould-Pasteur's disease will end up with rapidly progressive glomerulonephritis. So this is the antibody. Okay, so this is the antibody. This autoantibody is targeted against the antigen, especially to be specific, it targets the NC1 domain of the alpha 3 chain of type 4 collagen present in the glomerular basement membrane. So once this binding occurs, there will be recruitment of pro-inflammatory cells, lymphocytes, and there will be release of pro-inflammatory chemokines, cytokines, proteolytic enzymes. There will be endothelial cell detachment, there will be fibrin deposition, and finally there will be break in the glomerular basement membrane, and there will be leakage of plasma proteins and cells into the Bowman space, and this leads to formation of crescent formation. That is the classic feature of rapidly progressive glomerulonephritis. So if it affects this anti-GBM autoantibody affects only the kidney, we call it as anti-GBM disease. If it affects the lungs, that is the autoantibodies are directed against the basement membrane in the alveoli, then there will be damage to the alveoli, leading to leakage of RBCs into the alveoli and causing alveolar hemorrhage. So this is called as Gould-Pasteur syndrome, where both the kidney and the lungs are affected. So this is the picture of crescent formation. Here you can see there is rupture of the capillary wall. So this is a Bowman space, and the Bowman space is filled with fibrin, fibroblasts, proliferation of parietal epithelial cells is there, and macrophages, monocytes, and neutrophils, RBCs are there in the Bowman space. So this is a microscopic picture of crescent formation, which is a classic feature of RPGN. So in glomerular diseases, it is very important to know the immunofluorescence finding. Okay, so in anti-GBM disease, as we know that this antibody binds to the antigen, the GBM, so there will be immune deposits along the glomerular basement membrane, and this deposition is in a linear fashion, that is along the basement membrane. So we call it as linear deposits. Okay, so remember this in anti-GBM or in Gould-Pasteur disease, the immunofluorescence shows linear deposits. Okay, and there are in other cases like immune complex disease, we will see granular deposits, and in another entity called anti-neutrophil cytoplasmic antibody associated glomerulonephritis, we will not see or will see very minimal immunofluorescence deposits. So these are three types. One, we will see pauci-immune deposits or very light staining of in the immunofluorescence, and we will see linear deposits, and we will see granular deposits in immune complex glomerulonephritis. So we are done with anti-GBM glomerulonephritis or Gould-Pasteur's disease. We'll start with the next entity, that is anti-neutrophil cytoplasmic antibody associated glomerulonephritis. Anti-neutrophil cytoplasmic antibody associated glomerulonephritis. Okay. This is also called as pauci-immune necrotizing glomerulonephritis because on immunofluorescence studies we see no immune complex deposits or minimal immune complex deposits in the glomeruli. As a result, they have given this name pauci-immune necrotizing glomerulonephritis. Here, this ANCA is basically an autoimmune disorder in which the plasma cells in these patients will produce two types of antibodies, that is P-ANCA and C-ANCA. Okay. So this P-ANCA will act against this is an autoantibody will act against the myeloperoxidase, and this will further activate the neutrophilic granules, and the C-ANCA will act against the proteinase in the neutrophil, and this will further activate the lysosome function in the monocytes and macrophage, and this ultimately leads to inflammation causing renal vasculitis. So as I told you earlier, this is an autoimmune disorder in which the plasma cells of these patients will form two types of antibodies. One is P-ANCA and another one is C-ANCA. P-ANCA acts against the myeloperoxidase, which further activates the neutrophilic granules. This will cause a activation of the neutrophils. There will be recruitment of neutrophils to the recruitment of the neutrophils, and that will cause necrosis. And further, the C-ANCA will act against the proteinase 3 in the neutrophil, and this will indirectly activate the lysosome function in the monocytes and macrophages, and that will lead to vasculitis. Basically what happens is this P ANCA and C ANCA will activate the neutrophils and monocytes. So once the neutrophils are activated, this allows the extravasation of neutrophils out of the glomerular capillary. So the neutrophils will infiltrate or extravasate out of the capillaries and cause acute inflammation and necrosis. And monocytes begin to infiltrate as a second line of defense, as a second line, and over time the inflammatory process will cause chronic damage, causing scarring and fibrosis. And this is about anti-neutrophil cytoplasmic antibody associated glomerulonephritis. Remember, in this there will be no immune deposits in the immunofluorescence. So this is the second most important cause of nephritic syndrome. Obviously the symptoms will be oliguria, hematuria and proteinuria, and hypertension will be there in these patients. So I told you, in all the glomerular diseases we have to know the immunofluorescence findings. We'll see what are the immunofluorescence findings in this ANCA associated glomerulonephritis. Here you can see there are minimal or no immune deposits under the immunofluorescence microscope, hence it is called as quasi-immune necrotizing glomerulonephritis. So this is about ANCA associated glomerulonephritis. So next we'll start with immune complex mediated glomerulonephritis. So this we'll study under three headings. One is IgA nephropathy, and then we'll talk about post-streptococcal glomerulonephritis, and then lupus nephritis. As the name itself suggests, it is immune complex mediated glomerulonephritis. So there will be presence of immune complex deposits in the glomeruli. So in all these three subheadings, we have to know in which region or in which area of the glomerulus and these immune complex deposits are getting deposited. Okay, so in IgA nephropathy, which is the region, especially it gets deposits in the mesangium, and in post-streptococcal glomerulonephritis there will be subepithelial deposits, and in lupus nephritis there will be both mesangial, subendothelial and subepithelial deposits. So this is very important to remember in immune complex mediated glomerulonephritis. So we'll start with IgA nephropathy. So most important thing to remember in IgA nephropathy is there is mesangial and subendothelial deposits of immunoglobulin A. Okay. So what is IgA nephropathy? It is, as we all know, immunoglobulin A is an antibody that plays a key role in immune system, and it helps in fighting infections. This IgA nephropathy is also called as Buerger's disease. Okay, so here what happens in IgA nephropathy is this immunoglobulin A will start accumulating in the glomeruli, and because of this immune complex deposition, there will be inflammation leading to nephritic syndrome. But what is the exact etiology, we do not know. But the patients with these diseases are found to present with nephritic syndrome as a result of IgA nephropathy, especially patients with cirrhosis and hepatitis B and C infections, and also patients with HIV infection and few bacterial infections are known to cause IgA nephropathy leading to nephritis. So the symptoms of IgA nephropathy would be just like in case of nephritic syndrome. There will be cola or tea-colored urine as a result of hematuria. There will be foamy or frothy urine as a result of proteinuria, and there will be high blood pressure due to increased GFR and as a result of renin-angiotensin aldosterone activation. And here there will be, in addition to all this, there will be edema in the hands and feet. So I want to tell you that some of the glomerular diseases, especially IgA nephropathy and lupus nephritis, they cause both nephritic and nephrotic syndrome. So whenever in IgA nephropathy there is nephrotic range proteinuria, that is whenever there is the proteinuria is exceeding 3.5 gram per day, that leads to edema, that leads to nephrotic syndrome or edema in the hands and feet. So remember this. So this is about IgA nephropathy. We'll see deposits mainly in the mesangium and in the just beneath the capillary endothelium. So we'll start with the next entity in immune complex mediated glomerulonephritis. That is post-streptococcal glomerulonephritis. This is nothing but immunological response of the kidney due to infection by streptococcus. As a result, there will be sudden appearance of hematuria, proteinuria, and hypertension. And this is essentially a disease of childhood because it accounts for almost 90% of renal disorders in children. Okay. And this affects children within the age of 2 to 12 years. It is more common in males than females. And the causative agent is group A beta hemolytic streptococci. The clinical course would be the child will develop a upper airway infection followed by tonsillitis or pharyngitis. And after tonsillitis, that is after around 2 to 3 weeks, that is 14 to 21 days, the child may present with signs and symptoms of nephritic syndrome, that is oliguria, hematuria, hypertension. Or if there is skin infection, the child may present later by around 3 to 6 weeks. The child may present with same signs and symptoms of nephritic syndrome. How will you diagnose this case of post-streptococcal glomerulonephritis? So clinically, there will be features of acute nephritic syndrome, and there will be evidence of recent infection, especially with group A hemolytic streptococci. That will be confirmed by lab results of anti-streptolizin O titer, which is more than 200 units per ml. And also because of complement activation, there will be consumption of complement, so leading to low serum C3 levels. So main thing to remember in this is there will be deposits in the subepithelial region, and there will be presence of anti-streptococcal antibodies. So in immune complex glomerulonephritis, the second entity is post-streptococcal glomerulonephritis. Here there are subepithelial deposits and there is presence of anti-streptococcal antibodies in the serum. So this is about post-streptococcal glomerulonephritis. And the next entity would be IgA nephropathy in immune complex glomerulonephritis. Lupus nephritis. So when we talk about lupus nephritis, don't get confused with discoid lupus erythematosus. This because both of these are autoimmune disorder. Discoid lupus erythematosus, it affects only the skin. Whereas systemic lupus erythematosus, it affects both it's a multi-system disorder affecting the joints and skin and kidney. So when we talk about lupus nephritis, we are referring to systemic lupus erythematosus, which affects skin, joints, kidney, brain, and this is a fatal disorder. And the exact etiology of this is not known, but 9 out of 10 who have lupus are women. So there is female predilection. So the symptoms in lupus nephritis would be dark urine due to hematuria, foamy or frothy urine due to proteinuria, joint swelling or joint pain or swelling because it involves joints, and fever with no known cause because it is an autoimmune disorder. And I had told you earlier, lupus nephritis can also present with nephritic or nephrotic syndrome. So if there is nephrotic range proteinuria, that is more than 3.5 grams of proteins are excreted in urine per day, there will be edema. So how do we diagnose lupus nephritis? There will be low complement levels, just like in post-streptococcal glomerulonephritis. In lupus nephritis also there will be low complement levels, and urine analysis will show features of nephritic or nephritic syndrome. And most importantly, there will be presence of anti-nuclear antibodies. So this is the serological diagnosis, but more than this, histopathology is important. Pathologically, what we see in lupus nephritis is there will be deposition of IgG, IgA, C3 and C1q in the mesangium, in the subendothelial region as well as in the subepithelial region. So there is widespread deposition of immunoglobulin G, immunoglobulin A, C3 and C1q in the mesangium, in the subepithelial and subendothelial region. So all these immune complex deposits, they activate the complement proteins via classic pathway and lead to inflammation. So they will be reduced complement levels in the serum except in IgA nephropathy. Okay. So this is about immune complex glomerulonephritis. So there will be low C3 and C4 levels in immune complex glomerulonephritis except IgA nephropathy. So the immunofluorescence findings in immune complex glomerulonephritis would be the deposits are in the form of granules. Unlike in anti-GBM disease, the deposits were in the straight line. So we call it as linear deposits. Here they are granular. Okay. So this is the difference in immunofluorescence findings in immune complex mediated glomerulonephritis. There are granular deposits. In anti-GBM disease, there are linear deposits. In ANCA-associated glomerulonephritis, there are no or quasi-immune or minimal immune deposits in the immunofluorescence. So next we'll start with membranoproliferative glomerulonephritis. It is a type of glomerulonephritis or the inflammation of the glomerulus due to deposits in the mesangium and glomerular basement membrane. So this there is in this inflammation of the glomerulus due to immune complex deposits in the mesangium and glomerular basement membrane. You should not confuse this with membranous glomerulonephritis, where there is no involvement of glomerular basement membrane, only the mesangial proliferation will be there in membranous glomerulonephritis. Okay, and further, membranoproliferative glomerulonephritis is divided into type 1 and type 2. Type 1 is caused due to infections and autoimmune disorders, and here there is immune complex mediated activation of complement pathway, classic complement pathway. Remember this, in type 1 there is activation of classic complement pathway, whereas in type 2 there is activation of alternative complement pathway. And type 2 etiology, in majority of the cases are idiopathic, and few of the cases may be genetic. Because of the mutation, there is complement dysregulation here, and in this genetic disorders there will be autoantibodies against the complement itself, and there will be dysregulation of the complement pathway in type 2 membranoproliferative glomerulonephritis. And here there is activation of alternative complement pathway. In type 1 there is activation of classic complement pathway, and type 1 is immune complex mediated and type 2 is complement mediated. Whatever the mechanism is, microscopy of both are same. So coming to microscopy of membranoproliferative glomerulonephritis, there will be deposition in the subendothelial and in the mesangium. So there will be mesangial cell proliferation, there will be endothelial cell proliferation, there will be expansion of the mesangial matrix, and there will be reduplication or double contouring of the basement membrane, leading to what is called as tram track appearance. So the microscopy of it is important. There is proliferation, there is mesangial and endothelial proliferation and expansion of mesangial matrix, and there is reduplication of basement membrane, that is leading to tram track appearance. First, the most important thing is, because there is deposition in the GBM as well as in the mesangium, deposition in the GBM will lead to thickening of the basement membrane. Deposition in the mesangium will lead to mesangial expansion, because there is expansion of the mesangial matrix and also there is proliferation of the mesangial cells. And what happens is, here there is extensive proliferation of mesangial cells, and this will get interposed on this capillary wall. As a result, on this also there will be deposits. So this leads to tram track appearance or double contouring of the basement membrane. So this is called tram tracking of basement membrane. This is because of interposition of this mesangial cells on the capillary wall, and upon that also there will be deposits. As a result, they will lead to double contouring or reduplication of basement membrane, leading to tram track appearance. So this was about membranoproliferative glomerulonephritis. Now we'll study the last entity, that is rapidly progressive glomerulonephritis. Again, this is not a disease in itself, but all these entities, that is anti-GBM or membranoproliferative or ANCA associated, they finally end up in rapidly progressive glomerulonephritis. So RPGN is nothing but a disease of kidney which is characterized by rapid decrease in glomerular filtration rate by more than 50% or at least 50% over a short period of few days to 3 months. So whenever there is rapid decrease in GFR more than 50% within few days to 3 months, and along with that there is extensive glomerular crescents. This is nothing but increase in the cellularity in the Bowman space due to inflammation. So the causes of RPGN would be, as I told you earlier, it is not a separate disease in itself, but whatever the pre-existing primary glomerular diseases we had studied, that is IgA nephropathy, membranous glomerulonephritis or membranoproliferative glomerulonephritis, will end up in this RPGN, where there is rapid reduction in GFR and there is crescent formation, and also this autoimmune disorders like Goodpasture syndrome, that is anti-GBM, SLE, ANCA, HSP, or hereditary disorders, Alport syndrome, bacterial infection, post-streptococcal, even this post-streptococcal glomerulonephritis can also end up in rapidly progressive glomerulonephritis. Viral infections like rubella, hepatitis A, B, C, and even parasitic infections like malaria and filaria can also end up in RPGN. So rapidly progressive glomerulonephritis, it is also called as crescentric glomerulonephritis. It is not a disease in itself, but it can be caused by another glomerular diseases like anti-GBM, ANCA glomerulonephritis, immune complex glomerulonephritis. And the characteristic feature of RPGN is there is loss of glomerular filtration rate more than or at least 50% within few days to 3 months, and there is extensive glomerular crescents, that is the abdomen space is filled with inflammatory cells. There is accumulation of macrophages, fibroblasts, fibrin, and there is proliferation of parietal epithelial cells leading to crescent formation. So this is classic for rapidly progressive glomerulonephritis, that is crescent formation. So this finishes complete topic of nephritic syndrome. So first we started with definition of nephritic syndrome. We understood why there is hematuria, why there is proteinuria, why there is leukocyturia, and what causes oliguria, why there is hypertension, why there is azotemia. And then we started with anti-GBM disease. Here we know there are antibodies against the antigens in the glomerular basement membrane, and this if this disease affects lungs also, it is called Wood-Bachel syndrome. And here in this we are seeing linear deposits on the immunofluorescence, and 90% of these cases will end up in rapidly progressive glomerulonephritis. And further we studied ANCA associated glomerulonephritis. Here it is again autoimmune disorder. Here the patient's plasma cells will produce two types of antibodies, P-ANCA, C-ANCA. Basically they will activate monocytes and neutrophils, leading to vasculitis. And next we studied about immune complex glomerulonephritis under IgA, 3-8 IgA, and post-streptococcal and lupus nephritis. And then finally we studied membranoproliferative glomerulonephritis. Here there is classic triumph-tracking appearance of basement membrane, extensive mesangial proliferation, and thickening of the basement membrane. So this is all about nephritic syndrome. So do remember that some of the diseases, that is lupus nephritis and membranoproliferative glomerulonephritis, are known to cause both nephritic as well as nephrotic syndrome. So this finishes the topic on nephritic syndrome, and nephrotic syndrome will be dealt by Dr. Sanjay in the next class. Thank you.